let's dive right in. Today, we're breaking down a really critical editorial from the Cleveland Clinic Journal of Medicine. It's from Dr. Julian Perry, and it gives us a much-needed 5-year reality check on teprotumumab, a drug that, as you know, landed with huge expectations for thyroid eye disease.
And that title, A Reality Check, it just says it all, doesn't it? It perfectly frames the shift from that initial, miracle drug excitement to the much more complicated truth that we're seeing in long-term clinical practice.
So here's what we're going to cover. We'll look at its incredible debut, then get into the tough, real-world data. We'll unpack the science, this idea of a modulator versus a modifier, and then figure out what it all means for how we treat TED moving forward. Okay, let's get into it.
First, let's rewind the clock to 2020. I mean, this was a moment of just massive optimism for everyone dealing with thyroid eye disease or TED. A really hopeful time. Because this was a true game changer. We weren't talking about broad immunosuppression anymore. For the first time, we had a biologic therapy specifically designed to block the insulin-like growth factor 1 receptor on those orbital fibroblasts, a key actor in the whole pathophysiology of TED. It was incredibly targeted.
And wow, the early trial data was just so compelling. We saw these significant, really fast reductions in proptosis and inflammation. The excitement was palpable, and it's no wonder it led to such a rapid, fast-tracked approval.
Okay, but as Dr. Perry's editorial really drives home, 5 years of using this in the real world, well, it's painted a much, much more complex picture. So let's actually look at what that data is showing us. And here's the absolute crux of it. That durability we saw in the controlled trials, it just hasn't translated for the long term. We're talking about roughly 2/3 of patients losing that initial benefit in real-world follow-up. And this chart just lays it out so clearly. The drop-off is stark. You start with this fantastic initial response rate, 84%. But look, it falls to 57% at 1 year. And by the time you're 2 years out, only 1/3 of patients are still holding on to that benefit. That's a huge decay. And we're not talking about minor setbacks here. This is a full-blown reactivation of inflammation, a complete return to baseline proptosis. What's even more concerning is that these flares can happen late, which really prolongs that active phase of TED and creates a huge clinical headache when you're trying to time rehabilitative surgery. So this obviously raises the big question, why? Why is this happening? There's a really powerful way to think about this that helps explain these outcomes. And this slide just illustrates the core issue brilliantly. Is the drug just temporarily calming the storm, acting as a modulator, just suppressing the symptoms? Or is it fundamentally changing the disease's course, acting as a true modifier? Based on those high relapse rates we just saw, the editorial concludes that for most patients, teprotumumab is a powerful, very effective modulator. It puts a lid on the symptoms, but it doesn't seem to be durably altering the underlying autoimmune process itself. So, what are the clinical implications of this? What does this modulator versus modifier distinction really mean for you when you're sitting with a patient with TED? The logical next thought is, okay, so what about a second round of treatment for patients who relapsed? But it turns out that comes with its own very significant set of challenges. And a major concern here is ototoxicity, because that IGF-1R pathway is also expressed on outer hair cells in the cochlea. Blocking it can lead to some really serious and sometimes permanent side effects. We're talking sensory neural hearing loss. It's a big deal. And this all brings us to probably one of the most crucial aspects of our job, patient communication. We have to be really clear that while this treatment offers incredible relief, it might not be a permanent fix. It's all about setting those realistic expectations right from the start. Now, despite these challenges, let's be clear, teprotumumab is still an incredibly important tool in our arsenal. The focus is now just shifting towards how to use it more strategically. So the future isn't about ditching the drug, not at all. It's about getting smarter. It means better patient selection, maybe exploring different dosing strategies, and what seems most promising, really starting to embrace combination therapies. And this seems to be the most promising path forward, combining that rapid modulating action of teprotumumab with other therapies. For example, could we pair it with an IL-6 inhibitor like tocilizumab, or even revisit orbital radiotherapy to get more durable immunosuppressive control? These are the questions we're asking now. This quote from the editorial just perfectly captures this new perspective. It's not the whole answer, but it's a critical component of a much bigger, more sophisticated approach to managing this disease. So let's just sum it all up. The incredible promise of teprotumumab has been tempered by the complicated reality of its long-term performance. And that shift is forcing all of us to move beyond thinking of it as a standalone cure, and instead, to start integrating it as one piece of a much more comprehensive strategy.
And that really leaves us with this forward-looking question, doesn't it? How do we best fit this incredibly powerful but clearly imperfect piece into the broader, much more complex puzzle of managing thyroid eye disease for the long haul?